right, so we are going to start chapter 19 on the nutritional aspects of gingivitis and periodontal disease. All right, so I feel like at this point in the program, you should be pretty familiar with what gingivitis and periodontal disease are, but just to refresh, gingivitis is characterized by inflammation, swelling, changes in contour or consistency, presence of plaque biofilm or calculus or both, no evidence of attachment loss, and bleeding on probing. Okay, so pretty important is no bone loss, no attachment loss, and some bleeding needs to happen. Periodontal disease is a chronic, inflammatory, and infectious disease that is the result of a loss of connective tissue and alveolar bone. So the only difference between the two is really bone loss. All right, so then as far as the involvement for nutrition and its connection to periodontal disease and gingivitis isn't as clear-cut as it is for dental caries, right? Cavities are very straightforward. Nutrition is one of the biggest components. But when it comes to a inflammatory disease, there's a lot less of a perfect connection. So Healthy People 2020 broke it down that they wanted to reduce the prevalence of moderate and severe periodontitis from nearly 13% to 11%, and this is only in people between 45 to 74. And they wanted to reduce the prevalence of tooth loss from periodontal involvement. The primary initiating factors of periodontal disease is, of course, plaque biofilm accumulation around teeth and gingiva. So it has a slightly different etiology, right? Nutrient deficiencies, nutrient excesses, or any kind of imbalance, they don't initiate periodontal disease, right? That's bacteria. But they don't necessarily help your body fight the bacteria, so it could certainly contribute to the beginning of the disease. So therefore, nutrition may alter development, resistance, and or repair of the periodontium. That's probably the most sentence on this whole thing. So nutrition may alter the development, our body's resistance, and or our ability to repair the periodontium. Okay, so then how exactly does food composition, right, the nutrients that are in our food, how do they affect our tissue integrity and immune response? And they do so through these different ways. So in the normal growth and development for the periodontium and for the oral mucosa, that depends on vitamin A for salivary glands and epithelial tissue, vitamin C, which is important in collagen and connective tissue, and the vitamin B complex, all of the vitamin Bs, right, for epithelial and connective tissue. And then as far as the calcified structures, which we have whole chapters on these, this one is going to rely on amino acids, calcium, phosphorus, vitamin D, and magnesium. All of those are required in our diet in order to calcify the structures of our oral cavity properly. And then, of course, the maintenance for our oral tissues and making sure we stay, our immune system stays functioning properly is going to require vitamin A, C, and D, protein, of course, because it's in everything, carbohydrates for energy, calcium, iron, zinc, and folic acid. All of this is a review. We already had chapters that went over all of this information, but this is specifically for periodontal health. The consistency of our food is also going to play a role in our periodontal health, and it's less so like pH and all of that. It's more so just like how sticky and retentive the food is. So chewing very firm, coarse, and fibrous foods like raw vegetables and fruits, those are going to stimulate saliva. And that's a good thing because saliva will wash away the food and reduce that retention, right? But the book is fancy, so it's got to say it will enhance oral clearance. And then plaque biofilm that isn't physically removed is something that is going to be irritating to our tissue, right? It's going to cause inflammation when we don't remove it. So not only by eating fibrous foods is going to stimulate saliva, but also eating fibrous foods has a little bit of a mechanical removal itself, right? Especially on the occlusal surface. If you guys haven't already had a patient yet in practice or in clinic for when they have a tooth that isn't a part of the occlusion, maybe they're missing the opposing tooth, and you'll find pretty quickly that that tooth just gets completely caked, like the occlusal surface is just covered in calculus because there's no food like the chewing to remove the calculus. Other considerations that we should be making for our patients is going to be that if they are going through any type of stress, life stress, not just, regular people stress, tissue catabolism or infection, then they're probably going to need an increased amount of nutrients and energy, right? Anytime they're having to go through repair. We're going to talk about, healing from periodontal surgeries here too. We're going to be looking at their medical and social history in order to figure out, is our patient at risk for a nutritional deficiency? So if they are someone who's older than 65 and at the same time they're also reporting, that they've retired and they are they haven't picked up a hobby, they're kind of staying home, maybe they're putting on weight or, something like that, we may be able to find, okay, maybe this patient needs a higher amount of protein, right? And then also dietary counseling for all patients who for all periodontal patients is going to enhance their tissue repair and wound healing. It's going to improve resistance to infection and reduce the number and severity of complications. Typically in private practice, this works sort of like you are reading through their medical history and you'll come across maybe a medication that they take, or most of the time they're taking supplements of some kind, they're taking some type of vitamin. Anytime I see a vitamin, usually I ask, did your doctor prescribe that to you, or did you just feel like you needed it, kind of thing. And when it's the doctor has prescribed it to them because they are somehow deficient, I'll usually give them clue in on maybe some of good foods that they should have in order to try to help supplement that, because supplements aren't always the best source, right? The best sources of our vitamins are going to be through food. And then a lot of times people don't make the association that iron and calcium shouldn't be taken together. So, if it's a woman, typically, right, women are more prone to osteoporosis. If it's someone who has osteoporosis and they're taking a calcium supplement, well, then you probably want to tell them, hey, don't, eat a steak right before you take your calcium supplement, because there's a lot of iron in steak and that's going to impede the absorption of calcium. And then at the same time, if maybe your patient is pregnant and they're on a prenatal vitamin with iron, then you want to tell them, hey, don't drink this or don't take this with milk, because that's going to impede the absorption of iron, right? They're going to get in each other's way and you're not going to get either one. So sometimes just kind of going through some of those things that you've learned along the way, like trying to figure out, hey, what are they at risk for? And, maybe some tips I can give them that will help them to reverse that, right? Because we want our patients to be as healthy as possible. So when we talk about gingivitis, of course, a lack of nutrients does not cause gingival inflammation, okay? It does not cause that, but it can be one of the factors that will get in the way of our body's ability to repair tissue. So we're going to look at local and systemic factors, right? We're going to be looking at their immune system. Are they immunocompromised? Do they have an autoimmune disease, or do they have HIV? We're going to be looking at certain medications. Does this medication prevent them absorbing whatever it is? Remember, we talked about some of the anti-seizure medication will prevent being able to absorb certain vitamins. And then we're going to be looking at hormonal changes. Are they going through pregnancy or puberty or menopause? And then, of course, vitamin C deficiency can be an element because vitamin C is very important for, not only immune function, but also in our connective tissue and cellular turnover. And of course, we want to encourage vitamin C rich foods and having a well-balanced, nutrient-dense diet. And that, of course, has to go along with myplate.gov. Also, the intake of nutrients beyond the recommended amounts does not speed the healing process and can in fact be detrimental due to the interference with other nutrients or drugs. As far as periodontitis goes, the initiation and progression of periodontitis does not occur unless plaque biofilm is present. Okay, that bacteria has to be present. And this bacteria will actually grow faster if there is an excess amount of glucose and sucrose. Certain types of food, like soft, retentive, and/or fermentable carbohydrates, can enhance food retention and severity for inflammation. Systemically, nutritional status determines the immunocompetence of the periodontium. That's pretty straightforward. If you're healthy, your periodontium is healthier. Maintain nutritional diet and avoid retentive foods. So that would be the recommendation there, right? Is to have variety in the diet and to avoid foods that will stick to our teeth. If our patients are going to need periodontal surgery, there are a couple of factors that we want to remind them of from a nutritional standpoint. So before the surgery, we want to conduct a preliminary assessment for that patient in order to determine, do they have an adequate nutrient reserve? Do they have enough nutrients kind of in plenty in their body? All right, if they have any deficiency, then it's probably a good idea to have them supplement that nutrition before they ever have surgery, so that after surgery, when they're not able to maybe eat as well or as nutritious, then they're going to have plenty to get them through that post-operative. An elective surgery may need to be postponed for 1 or 2 weeks in order for that supplementation to occur, in order for us to bring up whatever that nutrient is. Medically compromised patients should be referred to a registered dietitian. So, of course, this is not something that we do in our office. These are things that we would screen them for and then refer them to a dietitian. And then patients should be given tailored meal plans listing nutrient-dense foods and beverages to choose or consume during recovery. So we want to give them all of the information about the kinds of foods they're going to have to eat after. That way they're able to kind of plan out what they want and also to purchase it ahead of the time, because they're not going to want to go shopping right after they get home from surgery. All right, and then after their surgery, we want to kind of account for blood loss and the increased catabolism, tissue regeneration, and host defense are all going to require that there is an adequate nutrient intake by the patient. It's important that they're still eating enough calories, right? Enough proteins, enough carbohydrates, enough fats, enough vitamins in order to heal properly. Dietary intake can be influenced by complications like anorexia, nausea, dysphagia, and oral discomfort. They're probably going to be uncomfortable orally, so that one's kind of a given. Because of this, we may need to adjust them to either a full liquid diet or a mechanical soft diet. Your book has the examples of a full liquid diet and a mechanical soft diet on page 372 and 373. The only bones I have really to pick with the recommended sort of diet here, and your book is kind of open, it meets calorie needs, it meets protein, carbohydrate, and fat needs, but it doesn't necessarily mean it's the healthiest for you. And my problems with it is that it has approximately 3,622 milligrams of sodium, which we're supposed to stay under 2,500 a day. It has 484 milligrams of cholesterol, which we're supposed to stay under 300. And then it only has 13 grams of dietary fiber. which we're supposed to get anywhere from 20 to 25 grams of, or 25 to 30, sorry, for men and women. So I don't love this example here. I think that they could have put some veggies and fruits and things like that into a blender and probably had something a little bit more healthy than what they have here. But a lot of the foods that you see here in the sample are things that are, they're cool, right? They're cool to the touch because, when you have any kind of wound or a lesion inside the mouth, you're going to want something that's more of a cold temperature. You're not going to want something hot in there. And then also all of it's really delicious and it comes kind of prepackaged and easy to make, which, when you're recovering from surgery, that might be something that you want. I don't know. I kind of feel like maybe they should go healthier for the book of nutrition, but that's just me. And then also we want to discourage any kind of smoking or the use of straws. And stop for a moment and just think, why would we want to discourage post-operative from periodontal surgery? Why would we want to tell them you absolutely cannot smoke and you cannot use straws? I'll leave you think for a second. You cannot smoke and you cannot use straws after you have periodontal surgery. This also applies if you have a tooth extracted. You cannot smoke and you cannot use straws. And the reason for this is because it's going to cause that negative pressure, right? Anytime you pull into the mouth or suck through a straw, you'll cause a negative pressure, and it can cause the blood clot that forms on the wound to get dislodged. Okay, so we don't want our patients doing that because it's going to slow down their healing process. Moving on to necrotizing ulcerative gingivitis, NUG, and necrotizing ulcerative periodontitis, NUP. They are going to be acute. And I know that all of this is a review for you from perio. But NUG is going to be characterized by red, shiny marginal, labial, and lingual gingiva that bleed when probed, and by cratered intradental papilla. So cratering of the intradental papilla is pretty important in order for it to be necrotizing and ulcerative, right? Grayish sloughing, that's the ulcerative part. Foul breath, it's sometimes a metallic taste. Occasional fever, and it is very, very painful. Nutrient deficiencies that are going to contribute to NUG, by no means do they cause, but they will contribute. Anything like a protein deficiency, a vitamin C deficiency, right? Maybe this is kind of a piggyback on scurvy, and or a vitamin B complex deficiency. And any deficiency of those three are going to lower that host resistance. As far as the recommendation from a nutritional standpoint when someone is suffering from NUG or NUP, we're going to probably recommend that they have either a very soft diet or a completely liquid diet, just until they're able to get into a healthier state. A good idea would be to provide examples of bland food and soothing food. And those are going to be things that they're on page 374 in your book. It's box 19.4. This is where it talks about a bland diet. And the things that you're going to avoid will be anything that has caffeine, right? You don't want any coffee, tea, soda, things like that. You're not going to want to have any alcohol. No peppermint, that's going to be, as my daughter likes to say, too spicy. No chocolate, no black or red pepper, right? Nothing too spicy. No chili pepper, no chili powder, no acidic foods like vinegar, things like that, and no citrus foods. Because when you're dealing with those ulcers, you want things that come in contact with that to be very soothing, not causing more irritation, right? We are going to want patients to have frequent small meals because it's going to be painful for them to put food into their mouths. So if they do that, they're probably not going to eat as much in one meal. So if we kind of give them little breaks in between, then they will be able to consume the calories they're supposed to. And then once they're kind of more stable and able to eat a little bit more, then you're going to go back to those dietary guidelines and to the MyPlate in order to try to bring them back up into health state. As far as like the etiology, right, we know that nutrition doesn't cause NUG or NUP, but it's kind of one of those factors that go along with it. So we know that NUG is usually caused by bacteria, of course, being the number one. The local health, so, any kind of plaque buildup and, bacteria counts that are in the mouth specifically. Systemic health is where nutrition plays a role in this, right? Because their overall health is important in their body's ability to fight this infection. And then also psychological. So are they going through a lot of stress right now? Those things will contribute to the patient having necrotizing periodontal diseases. All right, and so our dental hygiene considerations for that patient is going to be to encourage bland, soothing foods, like your book says gelatin or pudding. I've included here a couple of bland foods like crackers, oatmeal, plain bread. I don't know what's this bottom one is, some type of mash. Not really sure what that is. These are potatoes for sure, not lemons. This is rice here, bananas, oatmeal, things like that. Things that are very sort of not, any one way or the other. They're just kind of like blah. And you want to avoid spicy or acidic foods like citrus fruits, tomatoes, strawberries, things like that. They're going to be way too irritating. A liquid diet may be needed initially in order to kind of soothe that tissue, let it heal for a little while without causing any more irritation, and then advance the patient to a mechanical soft diet, which your book does go into as far as the types of foods you can eat on a soft diet, and then of course followed by the regular diet, depending on the patient and how comfortable they are. Like we already said, cooler temperatures are going to be more soothing whenever there's ulcerations. You're going to get them to eat probably a smoothie or ice cream more than you'll be able to get them to have like a soup or something. And then we obviously would want to refer them to a registered dietitian because we're not licensed and we're not supposed to be recommending changes to their diet. We just give recommendations on, foods that may be beneficial. We wouldn't want to tell them eat only these foods. So that is the end of the material portion of this chapter, but your book has a pretty good example of what a tobacco use assessment form might look like in this health application, which I think is really beneficial for all of us to read because these questions break down things a little bit more maybe directly than we might feel comfortable asking our patients. So when we ask, do you use tobacco? A lot of us will say, well, do you smoke, right? But smoking doesn't necessarily mean tobacco, right? What if they maybe smoke hookah or marijuana, right? So we want to be very direct in the things that we ask, and these questions are good at kind of getting that specific. So if you don't currently use tobacco, have you ever used tobacco? Maybe they quit yesterday and they're gonna start doing it again tomorrow, kind of thing, or as soon as they leave the office. And then how long ago did you stop using tobacco? And then if you smoke, what kind of tobacco are you using? So is it in cigarettes? Is it in cigars? Is it in pipe? Because, different types will determine, their level of risk. And then, of course, how much in a day are you consuming? And then chew or snuff. We're going to talk about this a lot in term 7 because you guys will end up doing a tobacco risk assessment. But chewable tobacco is actually more potent, and it is more addicting. It has more tobacco in it. It has, well, not tobacco, it has more nicotine in it. So it's very hard to quit. I know a lot of people, if they smoke, then they kind of get into a relationship and they start to have kids, they'll switch over to using like a dip or chewing tobacco because it doesn't have the smell of tobacco, but it's actually worse for them. So we want to definitely be keeping track of that. How long do you use, how long do you keep that chew in their mouth? And how often throughout the day are they using that? How many days of the week? Some people are like, oh, I only smoke on Saturdays after they drink or whatever it is. So we want to know that. And then how soon after you wake up do you first use tobacco, right? Because people who do it the second they wake up, they're probably very addicted, whereas some people, maybe don't do it until after lunch. And then does the person closest to you use tobacco? This one is probably one of the most important questions we ask as far as motivation level and their ability to quit. Because if their significant other smokes and is not going to quit, but they're trying to, their likelihood of success is really low. It's going to be very difficult for them to do so. How interested are you in stopping your use of tobacco? This one's really important because if they're not interested at all, like not whatsoever interested, then you're not going to convince them, okay? And that's okay. It's not your job to save the world. It's only your job to give them information when they're ready to hear it. Have you ever tried to stop using tobacco before? A lot of people are kind of serial quitters, like they quit and then they kind of relapse and they use for a while, but they want to quit, they just struggle. And so just because they've failed quitting in the past doesn't mean they're going to this time, and maybe this time they'll have some type of resource that will kind of push them over the edge in order to be successful. How long ago was your last attempt to quit? Maybe they tried quitting and they just started up again yesterday, and they're probably going to need a little while to try it again. And then have you ever discussed stopping with another physician, dentist or dental hygienist? This question is because if they're already getting, like whatever type of medication from their doctor, if they've already kind of reached out to the other resources, you're going to be redundant in giving them that. So just let them go to the source they feel is the best suited for this information, because those are the people they're going to listen to. It might be you, or maybe, just asking them these questions is the spark they need to go to their doctor. And then, have you decided to stop using tobacco completely during the next 2 weeks? How confident are you that you would be able to succeed, right? Whenever you set out to do something, if you're kind of doubtful whether you're going to be able to do it, then there's kind of a lower chance you'll be successful. But if, you set out to do something and you're like, no, this is the time, this is it, now or never, you're going to be more successful. Your book also kind of takes you through like a process in order to talk to your patient about it. So you're going to use those questions, but you're going to kind of go through this little flow chart. So first ask, obviously, if they're not using tobacco, they've never used tobacco before, then of course congratulate them, or congratulate them on quitting. You're going to advise them about how nicotine plays a role in oral diseases, and then you're going to assess their readiness, right? Those questions before. Do you want to quit? Have you ever tried to quit? How successful do you think you'd be, right? If they feel like they're ready, then this is when we want to give them information, right? They're ready to hear it. If we give them information before they're ready, they're not going to hear it. It's just going to go in one ear and out the other, right? And then obviously, if you give them information and they're like, okay, let's do it. Let's get started. Quit smoking. They then begin the program. And then if your patient says, you know what, today's the day. I'm going to quit smoking. I'm going to use these and these and these things to make me successful. This is my plan. I got it. I'm ready to go, right? They're going to start that day or tomorrow or Monday, or, everybody starts diets on Monday, right? So they're going to begin on whatever day it is. You're going to write down that quit date in their chart. and you're going to try to follow up with them 1 week after their quit date, because if they can make it 7 days, that's kind of one of those landmarks of quitting. Within a couple of days they start to have cravings, but after so many, then the cravings will go away, but the habits haven't gone away yet. And so there's a good chance that, they've made it through some of the hardest parts, but habits will bring them back around into, not even thinking about it. They'll light up without even having to actively decide. And so if you can reach out to them in order to, see how they're doing. If they're abstinent still from smoking, then you're going to obviously reaffirm those goals, and you want to congratulate them, because it's hard work. And then if they've relapsed, then you're going to want to talk to them about how, it's okay if you've had a cigarette, or, it's okay to slip up and make mistakes, as long as you continue forward and you keep trying. And we want to reestablish a quit date and kind of make a new one, and kind of keep them on the ball, right? We don't want them to think that we completely forgot about them, right? If they think, oh gosh, my dental hygienist is going to call me and check on me, I better do this, right? Patients feel connected to you no matter what you do, right? But they're going to feel very connected to you if you keep following up with them, and you're actively invested in their total well-being. All right, and then that's the end of chapter 19, short and sweet.